Today we will learn about the management of an important ECG. It is called the atrial fibrillation. So just a recap or a small presentation. What is atrial fibrillation? It is in ECG you will find irregular pattern or rhythm, as it is mentioned by you can see that R wave are in different positions that are not static or consistent. So irregular pulse is there and there is no P wave, no P wave. So there is obviously an ECG of atrial fibrillation. Now we will go to its management. That's important, as we are making this videos on only management and giving importance to the management. I hope you will learn more about the management. Now for management purpose, the three main question we have to answer, three questions we need to answer. There it is, the if AF is transient, that is it is there for small amount of time, or it is persistent. It is there for more than in transient we can say that is paroxysmal, small episode less than 7 days, but for more longer periods that is the persistent. And is there you have to find the cause. So is there any cause or factor, precipitating factor? Okay. And the third is the risk of the stroke risk. You have to identify the stroke risk of patient, okay. So these three are the main questions that we will answer or we will keep in mind for our management purpose. Now let's focus how we will go through. For second question, if there is any kind of cause, we have to give treatment of that diseases, like if there is any disease, chest infection or any lung disease like pulmonary embolism, you have to deal with those things, okay. And only treating the underlying cause, that will be enough, to treatment for the treatment of atrial fibrillation. And secondly, if it doesn't resolve, if you are treating the cause and atrial fibrillation is still present, then there will be an issue of either the rate control, some rate is more, and there is a rhythm control, as it is irregular pulse is there, so rhythm control, these two questions will be there. And so in any case, if it is persistent paroxysmal, and stroke preventive management is crucial, as I have mentioned in number 3 point. So let's start with now types of atrial fibrillation, specific treatment. So I am going now the first one, that is the paroxysmal atrial fibrillation, okay. That is for our understanding, I am making it smaller, like puff, paroxysmal atrial fibrillation. There will be persistent, that is also puff. So just parox, I am making it smaller in a way that you understand, that is the parox AF, okay. Now what is the parox AF? How will you treat? If it is small, there may be no treatment, you need no treatment in that case, paroxysmal. If it is short lasting and no symptom is there, you don't need to do any treatment, you can only observe. But if the patient has symptoms, different kind of symptoms is there, patient is having trouble with the symptoms, then we can go for the treatment, and the treatment can be, our first option will be the beta blocker. Okay, and it is also useful, you can give this patient if he has comorbidity of coronary artery disease or hypertension or heart failure. In that case, beta blocker is a very good option. Another option you can also give with the rate controlling drug, that is antiarrhythmic drug. Antiarrhythmic drug. So what are the option you have for antiarrhythmic drug? That is a 1C class drug. It is flecainide. Keep in mind the name, and the propafenone. Okay, it is also effective if you want to give the patient for preventing AF episodes, but you cannot give you cannot give this drug if the patients have the coronary artery disease, LV dysfunction. And moreover, this flecainide, if you give flecainide, you have to provide with beta blocker, so you have to use this rate controlling drug also, okay, to make it effective. Otherwise atrial flutter may develop. So atrial flutter prevention, you will give beta blocker with an antiarrhythmic drug named flecainide. Now third option you have, there is another class of drug, that is class 3 drug, antiarrhythmic drug, most effective, but you give it in the last days or in the refractory cases, that is amiodarone. Okay, amiodarone, this is the drug, and you can use it. And another option is dronedarone. So like dronedarone, but it is not given in the not given heart failure or LV dysfunction. You can use only in such cases amiodarone. It's a good option. There is another options of another drug, that is the calcium channel blocker, like diltiazem. Less effective than beta blocker if beta blocker is good, but if it is contraindicated, you can go with calcium channel blocker, but beta blocker is more than enough. Last but not the least, catheter ablation. If the patient want permanence or more preventive measures, develop preventive measures, as it has been seen in 75% of patients, it is prevented by catheter ablation. Okay, so we can use it, but there are some risk of catheter ablation. You will have to say about to the patients that what may happen: cardiac tamponade and stroke, phrenic nerve injury. So there are lots of problems, for that's why this is reserved. And pulmonary vein stenosis. So these are the side effects of the catheter ablation. So you'll have to give your patient the proper information that what problem he may suffer. Okay, so if I want to recap with paroxysmal AF, I can only say that in paroxysmal AF, you need no treatment if it is short lasting, no symptom is there. But the patient is having a lots of symptoms, you can give a best drug, first one drug, beta blocker. It is friendly to coronary artery disease, hypertension, even heart failure. And with that drug, it's not controlled. You can also add an antiarrhythmic drug. There are two types of drug, 1C and 3C. I will prefer that amiodarone, but we'll use it for refractory cases. So you can go with flecainide, propafenone, but if you use flecainide, you have to go the beta blocker. So beta blocker, and good option is the amiodarone. If it is not controlled by beta blocker, usually these patients have different kind of problem like cardiac, arterial, coronary artery disease and structural problem. So amiodarone, you will see you are doing or going for amiodarone with beta blocker. If it is not working or beta blocker is contraindicated, you can use or add calcium channel blocker. And last but not the least, the preventive more evidence based catheter ablation, but it has not risk free cardiac tamponade. Patient may suffer from stroke, phrenic nerve injury, pulmonary vein stenosis. So I think I can make you understand the treatment of paroxysmal atrial fibrillation. Now the second option, the second line of treatment, that is the persistent atrial fibrillation. So pars, that was parox, it is the pars AF. Now there are two side of this paroxysmal treatment. One is you have to do rhythm control. Second one is the rate control. In rhythm control, when you will choose this rhythm control, if the patient is having a significant symptoms, more symptoms, and there is also the underlying cause can be treated, patient is young, and if is less than 3 months and no major structural heart disease, so if you fill up that most of the criteria, you can go with the rhythm control. So when you will go, I am writing, please follow. If there is symptoms that is significant, if there is cause that is treatable, you are treating, and also you are controlling the rhythm in persistent one, and the patient is young, and if his duration is less than 3 months, patient has given you history, it's less than for 3 months, and no major structural heart disease. Okay, so these are the ways that you keep in mind for treatment with rhythm control. So how can we go with the rhythm control options? So at first we'll do cardioversion. If AF is presented to you with less than 48 hours, so there is again two type of option are there for you, for your understanding. One is the pharmacological cardioversion, and another one is the DC cardioversion. Pharmacological cardioversion options are two options. It involves IV. One is flecainide, as I mentioned above. One is 1C class, and another one is the amiodarone. It can be given 2 milligram IV for 30 minutes. You can go up to 150 milligram highest, but it is not good drug if the patient has structural heart disease. If the patient has ischemic heart disease or any structural heart disease, the good option is giving amiodarone, as I have also mentioned before. DC cardioversion can be given it is, as I mentioned, in less than 48 hours presentation you can give, but you have to assess the patient condition. If the patient also requires sedation there in DC cardioversion, and there is history of relapse in most DC cardioverted patients, so pharmacological good options. So patient is less than 48 hours presentation, go for cardioversion, can be pharmacological cardioversion option. Okay, and another is the DC cardioversion. Now if the patient is presented to you more than 48 hours, or you don't know the duration, no duration known, then how will treat the patient? Then we will delay the cardioversion. Delay cardioversion, will not do cardioversion. We will give anticoagulation for 4 months. Treatment of cause, and then we will go for, then we will do cardioversion if it is not resolved, and we will continue this anticoagulation even 3 months after that cardioversion. Now you are using rhythm control drugs, rhythm control ways, but it's not working. The patient's condition is not improving. Sinus rhythm cannot be maintained. So if no sinus rhythm, still with drug, or keeping in mind all other options are there, so we can go for rate control drugs. What are the rate control drugs there? So number 1 is beta blocker. Number 2 is a rate limiting verapamil diltiazem, and number 3 is digoxin. So you can go for one drug, combination drug, but don't combine these two drugs, never. It will reduce the heart rate more. Okay, don't combine them, but you can combine verapamil with digoxin. That's another good option. Okay, digoxin is more good in the sedentary person. Beta blocker, calcium channel blocker are better in exercise or functioning persons. Okay, so rate control, only rate control, it has been seen it can improve the cardiac function in MS. If there is MS and patient is suffering from AF, if you only control the rate, that will be enough. But if the sinus rhythm isn't maintained, you are controlling the rhythm and also the rate. Okay, you are doing these both too. And if there is option, if you cannot fulfill the rhythm control options, you can go with the rate controls, obviously. So up to now I think I had mentioned you about this important function, how we can treat it, but there is the last option. Except with you have been failed by rhythm and rate control, there is a permanent option of giving pacemaker. Your AV node, you will deliberately ablate it. Okay, you deliberately ablate it and you give a permanent pacemaker. So that is why it is known as the pace plus ablate method. used in the most severe cases when above options are not working, then we'll go for this last option in severe case and refractory cases. Okay, now we will give more important to another side of this treatment, that is the stroke prevention. Already we have mentioned about using anticoagulant drug in paroxysmal AF. So what about in persistent AF? Persistent AF you have to give, you know why it is there, but when you will start, if it is more than, as I mentioned, more than 48 hours, then you must give anticoagulation. So you will start this anticoagulant drug 4 weeks before cardioversion, and you will continue minimum 3 months. That is your duration of treatment with anticoagulation. Whom you will give, you have to do a risk assessment, 2 risk assessment there, for stroke, for bleeding. For a stroke, the assessment is known CHAD VAS score. I will explain it in later videos. Another one is the HAS for bleeding, HAS bled score. Okay, if HAS bled, it is seen the more than equal to 3, you have to monitor the patient closely, but it is not contraindication. And stroke risk is both the same in both AF, in a persistent paroxysmal. So it is your clinical exposure, it's your way of thinking that you have to prevent it and give proper treatment. Now for next way, our treatment purpose, we'll just talk about the anticoagulant options. So what is your AC options? So my AC options are that one is the doacs. These are the good options. First choice, that rivaroxaban, apixaban. These are the drug options are there. Edoxaban, dabigatran. There is no routine monitoring is there, fewer interaction of these drugs are present, effective as warfarin, as we commonly know the use of warfarin, but these drugs no need monitoring, so that's why we are using these drugs nowadays more. And when it is indicated, it is indicated after the risk assessment. So if your stroke risk, the adverse risk is more than 1 in case of male, that's enough to start the drug, and in female it is more than 2. And if you use this drug, it has been seen the prognosis that stroke risk reduces, 66% stroke risk is there reduction, but bleeding risk is there, and you will give the your patient, you should give some cautious information related to the bleeding risk. And most importantly, if this drug toxicity developed, or this drug is in the body, it is causing bleeding from this drug, there are some reversal agent. For dabigatran, the reversal agent is known as idarucizumab. And for apixaban, rivaroxaban, it is andexanate alpha. For this one, andexanate alpha. Okay, these are the antidote. Aspirin we don't give in this patient, that it has not been so much useful. But after drugs, there is another option, is the warfarin. If anyway you cannot give drugs, you can give that warfarin. INR target should be 2 to 3, and here reversal drug is the vitamin K, or you can give the clotting factors. Okay, so these are the treatment options. So if I review again the treatment of persistent atrial fibrillation, this persistent atrial fibrillation, in persistent atrial fibrillation, from the name it is persisting in the sense the duration is prolonged and it is more than 7 days. Okay, and you do with a rhythm control treatment. But for rhythm control or rate control, in rhythm control the patient has significant symptom with the problem, otherwise no symptom, you can give some rate controlling drug and see the rhythm is controlled or not. And then you have to treat the cause, find out the risk factors, and if patient is young and AF is very smaller times, for less than 3 months he is suffering from these episodes, so long prolonged episode, and there is no major structural heart disease, you can go with the cardioversion. So how cardioversion? If the patient presents with this time it's episodes with less than 48 hours episode, and you can give the pharmacological cardioversion as the patient is having symptoms. Pharmacologically, if the patient is having symptom, you should give IV flecainide, but you must know that no structural disease should be present. So this drug has some limitation, but for good is amiodarone. Okay, if there is heart disease, heart problem, you can go with this one. And second option, in less than 48 hours you can also give the DC cardioversion also, but there is also relapse rate is more here. So good, you be hospitalized and give amiodarone IV. But if it's 48 hours and you don't know the duration, you have to delay the cardioversion. You should start the anticoagulation. I will later explain the anticoagulation options and treatment of the cause, then cardioversion, and also continue it. Okay, and another option is the last but not the least, with anticoagulation. If these are not working, you can go pace and ablate method. You will give a pacemaker and you will ablate the AV node, so problem is permanently gone. Stroke prevention, you whatever you do, you'll do the stroke assessment, risk assessment, and the bleeding risk assessment. By combining these two assessment, and you will see the treatment, how you will proceed, you will understand it. Okay, now you have to monitor it for bleeding. You will make counsel the patient about the risk options also. So what are the anticoagulants? Doacs, rivarox, apixaban, edoxaban, dabigatran, these are the options. And it has been evidence that this reduce the stroke percentage. If you will start those drug in, if the the stroke risk is more than 1 in male and more than 2 or equal to in female. There is reversible drug idarucizumab for dabigatran, and for rivaroxaban, apixaban, and dexanate alpha. Another option is warfarin, but as it needs monitoring, you have to monitor that INR level. There is side effects also there, and you usually you have to monitor it closely for bleeding purpose. So for vitamin K is there still, but the good option is now doac. Okay, main option is you don't need any monitoring. So I think I tried my best to make you understand that treatment of AF. In paroxysmal option, I also mentioned how it works, and in persistent one, I have gone with that anticoagulation option. Okay, so anticoagulation option, already I mentioned that when we will start it in less than for 48 hours, you will, if is more than 48 hours not working, you will go for this anticoagulation option. For stroke risk management is always there, for any type you can go with treatment. So that's all. Thank you very much, and be with my channel.